In this video, we'll discuss minimal change disease. Minimal change disease is a renal disorder in which injury to podocytes in the glomeruli leads to increased glomerular permeability and loss of protein in the urine, resulting in nephrotic syndrome. It's the most common cause of nephrotic syndrome in children, but can develop in adults too. In order to understand the pathogenesis of minimal change disease, let's first review the normal structure of the glomerulus. The glomerular capillary wall has three main layers. First, the visceral epithelial cells, called podocytes, are octopus-like cells. They have interdigitating foot processes that cover the urinary side of the capillary. Adjacent foot processes are connected by a protein complex called the slit diaphragm. The next layer is the glomerular basement membrane. Last, the capillary lumen is lined by fenestrated endothelial cells. Together, these layers form a negatively charged filtration barrier that restricts the passage of molecules from the capillary lumen to the urinary space. This is based on molecular size and charge. The barrier is permeable to water and small solutes. However, cells, large molecules, and negatively charged molecules like albumin are prevented from passing. In minimal change disease, the filtration barrier is disrupted. The underlying cause is unclear, but it is thought to be due to dysfunctional T cells, which result in production and release of a glomerular permeability factor. The circulating factor damages the podocytes, leading to effacement of the foot processes. This means that the foot processes appear flattened with loss of the slit diaphragms. The factor also decreases the negative charge of the glomerular capillary wall. As a result, the filtration barrier becomes dysfunctional. There is increased permeability to negatively charged plasma proteins, particularly albumin, causing selective proteinuria. In most instances, the specific underlying trigger is unknown. However, some cases have been associated with drugs, infections, atopic disorders, and malignancy, emphasizing the likely role of immune dysfunction in the pathogenesis. Patients with minimal change disease present with the hallmark features of nephrotic syndrome, including massive proteinuria, which causes frothy urine, and hypoalbuminemia, due to the loss of albumin in the urine. Hypoalbuminemia causes a drop in intravascular oncotic pressure, as well as salt and water retention, which results in edema. It typically first develops around the eyes, followed by the genitals and lower extremities. Finally, in an attempt to restore the oncotic pressure, the liver increases synthesis of both albumin and lipoproteins, which can cause hyperlipidemia. In children with classic clinical findings, minimal change disease is usually diagnosed presumptively because it is by far the most common cause of nephrotic syndrome in this age group. Adults with nephrotic syndrome, however, typically undergo renal biopsy because of the increased likelihood of other etiologies. When biopsy is performed, light microscopy shows normal glomeruli, which is why the disease is termed minimal change. The podocyte damage cannot be visualized at this power. Immunofluorescence studies show no immune deposits, indicating that the pathogenesis does not involve immune complex deposition. The key finding is seen using electron microscopy, which shows podocyte foot process effacement. In this biopsy, here is the capillary lumen, which is lined by fenestrated endothelium, and here is the glomerular basement membrane. Rather than discrete foot processes lining the basement membrane, the foot processes appear flattened and continuous, characteristic of effacement. Remember, foot process effacement is not specific to minimal change disease. It can be seen in other proteinuric glomerular disorders. What makes minimal change disease unique is that foot process effacement is the only significant pathologic finding in the glomeruli. Because minimal change disease is likely immune-mediated, initial treatment is typically with corticosteroid therapy. The vast majority of patients respond well to steroids and achieve remission within weeks to months. To sum up, here are the key points to remember. Minimal change disease is the most common cause of nephrotic syndrome in children. It's likely caused by dysfunctional T cells that cause production of a circulating factor that injures glomerular podocytes, resulting in nephrotic range proteinuria, hypoalbuminemia, and edema. When renal biopsy is performed, light microscopy shows normal glomeruli, and electron microscopy shows foot process effacement. Most cases resolve in months with corticosteroids.